Welcome back, everybody. It's my pleasure to introduce our speakers for today's debate. The debate is patient-centered outcomes are preferable over outcomes based on randomized controlled trials. We're really lucky to have the two sort of keynote debaters here today. I would ask that they avoid pettifoggery. Is that okay, Dr. Finkelstein? No? Going first today will be Dr. Fred Finkelstein, who's a clinical professor of medicine at Yale. Dr. Finkelstein is a very accomplished scholar, clinician, and leader in clinical nephrology. I think what's really remarkable about him is his outreach beyond to the U.S. and beyond, and all the great work he does in providing dialysis to those that otherwise wouldn't have access. So with that, Dr. Finkelstein, will you give it your best shot?
Thanks. Thank you very much, Mark. It's a pleasure to be here and debate with Glenn Chertow on patient-centered outcomes, which in my mind are the ultimate goal of healthcare delivery, where we need to focus on the individual patient. So we can look at healthcare from a global perspective, where you take a distant view of the globe and you see everything from a distance. But is that what we want to do when we manage patients? Really, we want to focus on the individual. And what are that individual's goals and concerns? And that was very well captured in this statement by Rita Sharon, who's the chair of the Department of Medical Humanities and Ethics at Columbia Medical School, which is my alma mater. They just opened this sort of whole department now of humanities and ethics. And what Rita talks about is summarized here. In medicine, we get very good about talking about the human body, but we get dumber and dumber about paying attention to the individual. And that's what humanities and ethics is all about in medicine. So let me digress from healthcare for a while and talk about a couple other things. I want to start by reviewing what the FAA's response was to the crash of the Boeing MAX jet. So the first jet crashed, and the FAA did an analysis. And they found that without government intervention, the MAX was likely to crash 15 times over the next 45 years, potentially killing 2,900 people. And they thought that was fine, because the mortality rate was going to be extremely low, and there was no need to be concerned about that. The second jet crashed, and they thought about it for a second, and they realized they'd made a mistake. And as the New York Times says, despite its own calculations, the FAA rolled the dice on the safety of the traveling public. So the FAA could say the mortality rate is low, only 2,900 people are going to be killed, but what's the impact for the individuals and their families? That's what was ignored. Let's turn to the art world for a minute, which is something that I'm particularly interested in. I want to start by just giving a quote by Michael Kimmelman, who is a New York Times art critic. He says, "Art is not just about what's great or famous. It's a mirror where you hold up that looks different to everyone who sees it, and the beauty lies in us and our capacity to dream." That the beauty lies in the way each individual perceives the artwork. So let me ask you, which painting do you like better? There's a Claude Monet painting from Giverny from about 1900 on the left, and a Cy Twombly painting on the right from the National Gallery in London. I think most people would say the Monet painting is a far better painting, but I actually think the Cy Twombly painting is much better. And if anyone has a chance to go to the Broad Museum in downtown Los Angeles, there's a whole room full of Cy Twombly paintings. And what they write about that is what's so special about these Cy Twombly paintings, they force you to think about what's true and what's beautiful. Whereas the Monet painting, you just see it and you can take it in basically at one glance. So it challenges you to think as an individual about what's true and what's beautiful. And that was very nicely captured by Eric Kandel, who's a Nobel Prize-winning neuroscientist at Columbia, who wrote a book, The Age of Insight, talking about Vienna around 1900. And he notes that we need to understand that each individual, because of unconscious and conscious processes, sees the same painting or experiences the same event, experiences dialysis or CKD differently, uniquely interpreted and reconstructed by his or her brain. Again, the focus on the individual. Another example from the world of art is the show that's at the Guggenheim in New York now. And it's a show called Artistic License, where 6 artists from around the world pick paintings from the Guggenheim's collection, and then it's displayed in the rotunda in the Guggenheim Museum. But these are artists from around the world. I'm going to focus on one, Richard Prince, who's an American artist who does a series of paintings about nurses, so I thought it was appropriate to discuss it here. But he also appropriates images, such as the one on the bottom, from the old Marlboro ads from several years ago. And what Richard Prince talks about, and what the show is basically about, is redefining the way we look at art. And the same thing is true if anyone goes to the new Museum of Modern Art in MoMA. The museum's been rehung. And the focus has shifted from the traditional way we think of contemporary art as progressing from Impressionism to Cubism to abstract expressionism to minimalism, etc. That really doesn't hold water when you look at art from a global perspective. And what Richard Prince writes is that art witnesses and demands accountability, but it also envisages the possible. And an art history written from a global perspective must acknowledge the myriad and diverse voices of the individual and the poetic and miraculous inventions of each of these individuals. You need to focus on the individual, and just sort of forcing art into these standard algorithms, for example, is not the right way to look at it. And that's very nicely and powerfully captured in the show at the Guggenheim. So let's go back to medicine now and talk about medicine. So patient-centered care and personalized medicine is a new focus in healthcare delivery worldwide, where we need to understand each patient's experience and goals, recognizing that each individual is unique, as I just discussed, and with appropriate adaptation of therapies to meet each individual patient's needs. And this is the gap in nephrology. The global view is not sufficient, and we must pay attention to the individual, something we've not done in the world of nephrology. So nephrology has lagged far behind other specialties in developing personalized therapy. What we have not done is shown on the left, and what we have done is shown on the right. We've not focused on the individual patient's needs. We focused on CKD and ESRD care patients in aggregate. We routinely assess. What we have not done is to routinely assess in a meaningful way patients' health-related quality of life. We have not incorporated HRQOL assessments and patient-reported outcome measures into routine patient care. We have not done is tailor and adjust therapy based on assessments of individual patients' needs and goals, not on the basis of large-scale clinical trials. What we have done is relied on big data to direct practice patterns and relied on practice guidelines established by LDOs, CMS, and others, for example. We have lost the ability to focus on the individual. For example, look at the 5-star ratings from CMS and look at the quality reimbursement programs from the QIP. Does any of this have to do anything with the individual? The only thing that talks about the individual is the CAP survey, which are given twice yearly, and well less than half patients fill this out. And from our perspective, this is basically a useless survey. The survey focuses on patient satisfaction with care delivered, not on individual patient goals and needs. And from my mind, it's pretty much a useless survey that most patients don't fill out, and no one ever gets any feedback on what they've responded in the questionnaires. But these things are all focused on laboratory measures and laboratory assessments. There's not a thing here about an individual patient. And that is really a huge problem. But the world of medicine has changed, and let me just give you a couple examples. This is from a paper that was just published last month by Mary Tonetti, who's head of geriatrics at Yale. It's a non-randomized clinical trial of 366 patients with 3 or more comorbidities, like all of our patients have, cared for by providers focusing on patient care priorities and those providing usual care. Importantly, there were significant improvements in healthcare and reductions in treatment burden and unwanted healthcare in those receiving care focused on the individual patient care priorities. And the editorial that accompanies this article captures this very nicely. It says, too often, we see patient care focused on labs such as hemoglobin levels, hemoglobin A1C, that are generic, designed to improve the healthcare team's performance measures, as we all do in dialysis units now, but are disconnected from the realities and complexities of the patient situation. So we're focusing on getting our K to V's over 1.7 in PD patients so we can meet CMS's goals, but what does it have to do with the individual patient? That was discussed very nicely by Isaac Teitelbaum yesterday in his talk on the new high-priority PD guidelines. Or a paper again last month on patient perceptions of diabetes guidelines. A study of 386 patients, recruited patients 65 years with diabetes, and how they perceive factors used in guidelines for diabetic care. And their conclusion was that many older patients did not place high importance on factors recommended by guidelines. And in fact, many older adults weighed various factors in the opposite direction than the guidelines. So what are these guidelines telling us to do, and what does it have to do with an individual patient care? How often do we make that mistake in dialysis, particularly with older patients, as was captured in this study? But look at this study now in CKD patients, also published in the last couple of months in JASN. They looked at 382 advanced CKD patients, stage 4 or 5, over 60 years old, and responded to the question, if you had a serious illness, what would be important to you? There were multiple replies that came back, but importantly, only 20% have opted for live as long as possible. The most common responses were, do not suffer, that was 35%, and I apologize, it didn't come out the way it should have really. And 33% wanted care to focus on comfort. Survival rates were not anywhere near the top priority for these patients. These are patients that we see who are going to be starting dialysis, basically. So their concern is patient comfort and their individual patient concerns and goals. It is not patient survival. And what do we focus on in our randomized trials? We focus on patient survival. That's really what we focus our attention on. And that has stimulated the interest in the SONG initiative that Alison Tong will be discussing. There has been no substantial improvement in HR quality of life outcomes for patients on hemodialysis due to problems in the selection of outcomes, which usually focus on biochemical measures, which are often of little or no relevance to patients. And the SONG HD initiative is trying to develop outcomes of relevance to patients, caregivers, and health professionals. So SONG is doing this now for hemo patients, it's doing it for PD patients, and presumably CKD patients as well. So let's talk about randomized trials and big data. Nephrology keeps insisting that truth is based on large randomized trials and analysis of big data, the USRDS, DOPS, LDO databases, for example. But how does this information apply to the individual patient? And while many specialties have moved away from this approach, nephrology, it seems to me, remains mired in the past and has not moved forward the way it really should have. Let me give you a couple examples of this, for example. I'm just going to cite two of these, the TREAT trial in anemia management, the FHN trial on home hemodialysis. So just to refresh your memory briefly on the TREAT trial, it studied over 4,000 patients with diabetes, CKD, and anemia, and were randomly assigned to high and low hemoglobin levels, which were 12.5 and 10.6. The primary endpoints were a variety of death and cardiovascular endpoints. In the trial, there were no difference in outcomes in terms of mortality, heart failure, MIs, composite cardiovascular endpoints. The only difference was in the incidence of strokes, which was slightly higher in the higher hemoglobin group than the lower hemoglobin group, and that's shown on the graph on the bottom, a slightly higher mortality rate. They also looked at secondary endpoints, including health-related quality of life, and the primary health-related quality of life analysis was the change from baseline to 25 weeks in the FACT-Fatigue score. And in this, there was a greater degree of improvement in the mean score in the darbepoetin treated group than in the placebo group. So statistically significant, but was felt not to be significant because the increase of 3 points or greater was considered to be a clinically meaningful event, and this didn't occur in the average patient who was being treated. So what was the conclusion from the TREAT, and the same was true from the CHOIR and CREATE study, was that increasing hemoglobin levels is bad to do because it increases the risk of stroke. It goes up 2% higher in one group, and that there was no advantage treating health-related quality of life because of these mean values, which really significantly improved, but were felt not to be of clinical relevance. And is that really true? And the answer to that is probably no. So when KDIGO came up with its guidelines for how to treat anemia, it said in general we suggest that ESA is not be used to maintain hemoglobin levels above 11.5 in adult patients. However, the experts realized that individualization of therapy is necessary, as some patients may have improvements in quality of life at hemoglobin levels above 11.5. and will be prepared to accept the risk. The slight increase in risk of stroke in those patients is superseded in the patients by the health-related quality of life. And let me give you a case example. This is an actual patient who we managed in New Haven, an 84-year-old retired Yale history professor with CKD who had an eGFR of 16, at a slowly declining hemoglobin level to 10.2. He's still actively involved in writing academic articles. Physical activity is limited because of advanced heart failure. He reports that he has difficulty finishing his academic work. He's writing a book, and he attributes this to difficulty concentrating and focusing on research and writing. Because we had little to offer him, we started ESA therapy. This would not have been approved by CMS because his hemoglobin was above 10, but we did it anyhow. We got his hemoglobin up to 12.5 to 13, above what the standard targeted guidelines would be. We explained to him there might be a slighter grade risk of having a stroke or having a cardiovascular event. But what was important to him was finishing his academic work. He then reported a striking improvement in his academic productivity, but no change in his physical activity because of his heart failure. And the guy was able to complete his book, accepting the slightly higher risk of a cardiovascular event. This would, on the CMS guidelines, we would get no reimbursement because we started above 10 and because his hemoglobin was sitting up between 12.5 and 13. You could ask yourself, what was the right thing to do for this patient? So let me talk about the frequent hemodialysis network, and I'm going to cite two papers by my esteemed competitor in this debate, Glenn Chertow. The FHN trial randomized patients to receive 6 or 3 hemodialysis treatments per week for 12 months. Favorable effects were noted on the primary outcome of death, change in left ventricular mass, and death or change in physical health scores. The long-term mean 3.6 years effect of frequent hemodialysis demonstrated a relative mortality hazard for frequent versus conventional that was significantly lower. Now, these trials, the data for the FHN started coming out in 2009, 2010, and there have been a series of publications since, all supporting the same idea that frequent hemodialysis is a good thing to do. It improves outcomes, and people are going to live longer and have better left ventricular function. But look what's happened to the trends in home dialysis that are shown here. This is from the USRDS from 2019. So this is home dialysis now. The line on top is the gray line, is a dramatic increase in peritoneal dialysis because it's an initiative now to grow home therapies. The line on the bottom, the black line, is home hemodialysis. There's been no increase in home hemodialysis therapy in the United States, despite the fact that the FHN trial has shown you can reduce mortality rates, improve left ventricular function. So why is that? What is the problem? Is it the patient burden? What is going on here? And I'll suggest to you that simply knowing that mortality rates goes down is not sufficient to drive up a treatment modality. Patients are more concerned with other issues in their lives. And I'd suggest that the patient burden for this is what limits home hemodialysis. And you can look at the data from Canada where you have the same experience, that home hemo has not grown particularly in Ontario despite a major push to grow home dialysis therapy. And the major increase in home therapies has occurred in peritoneal dialysis. Nephrology is starting to change though, but it's changing very slowly. So people are now recognizing and reassessing the importance of individual and HRQOL assessments, incorporating these into routine care. There was a series of papers in C. Jason in 2017. It's becoming more of a major focus in the US and around the world. Speaking to people in Europe now, they're incorporating HRQOL into routine management of patients, for example. But what instruments should be used or what the challenge is? So CMS is making its plans. Those are in evolution now. There's a position statement from the Kidney Care Quality Alliance in 2017. There's a technical expert panel in 2017 that all stress the importance of health-related quality of life assessments. I want to talk briefly about the KDIGO conference from 2018 to 19 and about the new ISPD guidelines that have come out. So the KDIGO met in Madrid in 2018, and Chris Chan was the first author on the paper in Kidney International. It just came out last year. And this is recognizing the shift that the primary goal of treatment is to understand, identify, and try to meet individual patient goals and objectives. To provide basic level of end-stage kidney disease care, do your dialysis treatments the way you should, but including the amount of dialysis and anemia management, get your hemoglobins where they should be. But you have to look at these in the context of the individual patient's experience. You need to focus on the individual and not simply focus on these guidelines of care for hemoglobin, dose of dialysis, etc. And the IFPD guidelines that Isaac Teitelbaum discussed yesterday with you, and this paper again was just published in PDI, is talking about a holistic approach to assessing the adequacy of peritoneal dialysis, to move away from the focus on labs such as KTV and hemoglobin, and focus on each patient's goals with an emphasis on adjusting the targets of therapy and the dialysis regimen to permit the patient to achieve these goals. And that's what our focus really needs to be on. So there are lessons we can learn from other specialties, and I'll just give you a couple examples of this. There's this wonderful paper by Rottenstein in New England Journal of Medicine in 2017. It's a review article where he's arguing that the routine use of patient-reported outcome measures in routine care results in improved physician satisfaction, improved communication between patient and doctor, enhanced shared decision-making, and enhanced workflow efficiency. And he goes through multiple examples from other specialties. If you haven't read this article, it is really extremely well written and makes the point very cogently. Oncology has really moved to incorporating patient-reported outcome measures into routine care. And there's a very nice paper, again, by Ethan Bash in the New England Journal, also in 2017, where he argues that for patients undergoing chemotherapy, treatment value cannot be summarized in an individual metric, and that a multifaceted approach is necessary, focusing on what is important to the individual patient. And he's focused on electronic testing of patient-reported outcome measures, which has been shown to be beneficial in several domains. It improves the clinician's experience, the patient's experience, provides feedback to healthcare providers and how care should be adjusted for the individual patient. And importantly, this is a randomized trial of incorporating electronic PROMs into oncology, where emergency room visits decrease and patient survival really improves. So again, incorporating these into routine care results in improved outcomes. And I just want to show you these ads from Sloan Kettering, the cancer hospital at Cornell in New York. There will never be one cure for cancer, there will be millions. And they say, Memorial Sloan Kettering specializes in you, our team of doctors, nurses, and the cancer experts will create a plan that's tailored to your exact needs. They're not going to put you into a protocol, into a randomized trial. They're going to tailor the care for your own individual needs. Psychiatry has also used electronic PROMs and computerized adaptive testing. They've used this to diagnose major depressive disorders, anxiety disorders, bipolar disorders. They've routinely incorporated these into routine care of patients. Importantly, you can reduce the burden of questions. You can give the questionnaires repeatedly, and there are good responses from patients because the questionnaires change depending upon their responses. And importantly, you can monitor patients with psychiatric illnesses, and if depression scores change, for example, notifications can be sent to the healthcare provider to make an intervention. Is this something we were thinking about in nephrology? Well, a study that was recently published from the UK looked at the use of electronic PROMs and how patients with chronic kidney disease would respond to these. And it's the study, the conclusion I'm just going to show you here without showing you the data, were that patients were willing to complete electronic PROMs on a regular basis as part of their care, despite clinician concerns about patient burden. So clinicians were worried patients weren't going to do this, but that's not in fact what happened, and patients were willing to do it. And in a paper I presented on Tuesday at the Renal Research Institute board meeting, we just completed a pilot project looking at computerized adaptive testing in CKD and peritoneal dialysis patients. We gave this to about 200 patients. They almost all agreed to participate. They were elderly. It took about 10 minutes to complete the questionnaires. Most patients can complete it without assistance. And importantly, the patients who completed it, they almost all completed the second and the third questionnaires when these were basically given. And the reason this was done and it was so useful, patients completed the questionnaires, the results were printed out and given to the healthcare provider at the time of the visit. So there was instant feedback that was given. Unlike what happens in dialysis units now, where patients complete questionnaires and there's no feedback given to them, and they say, why should I do this, basically? But this is instant feedback to patients based upon their responses, so the care can be adjusted to meet the patient's needs. So in summary, nephrology needs to expand its focus on the individual patient. This requires seeing each patient as an individual and tailoring care to meet the patient's needs. It needs to look closely, nephrology, at what is happening in other specialties and learn and adapt from these experiences. Importantly, nephrology needs to understand that simply relying on large data sets and randomized trials to direct healthcare does not lead to personalized healthcare, which is where the future of healthcare clearly lies. Thank you.
Dr. Finkelstein, thank you for that very well-reasoned and civilized argument. I hope Dr. Chertow isn't confused by the art history lesson. Debater is Dr. Glenn Chertow, who will advocate for randomized controlled trials. Dr. Chertow is a professor of medicine at Stanford and division chief there. Glenn is the perfect person to argue this point. I think that he has really participated or led in dozens of really key clinical trials in nephrology. His influence is even multiplied by the legion of trainees and that he's had at Stanford and at prior institutions. And these trainees are just the leaders, the next generation of leaders in nephrology. So Glenn's prowess as a debater is also renowned, so it should be exciting. I think if he wasn't such an accomplished professor, he would be sort of an artist of the spoken word, like Macklemore or something. So, Dr. Chertow, we're excited to have you.
What a pleasure to be here. I'd like to thank Dr. Katenko for his invitation. I'd like to thank Dr. Unruh for his beautiful introduction. With the time remaining, I'll get to the debate. This won't actually be much of a debate, I don't think. Dr. Finkelstein, whom I revere and admire greatly, obviously was trying to confuse you and obscure things with a bunch of art. I'm a devotee of a different type of art, so we'll share some of that in a moment or two. But I just entitled this "Wake Up! We Need More RCTs to guide practice in nephrology." So I ask and remind us that we will have a civil discourse today. I might have to lower my glasses down to my nose, like our friend from New York, Chuck Schumer, or as my mom says, Schuma, Chuck Schumer. But while we are having a civil discourse here, our colleagues in the Senate, the revered body of government, are having a much less civil one. So ground rules for today, and I wasn't sure if I was going first or second. First, of course, mutual respect and admiration, at least from my direction. And I said I am likely to agree with much of what Dr. Finkelstein has to say, but I'm not so sure now. I definitely want to make a point or two about clinical trials and how we refer to them. And I definitely want to emphasize the fact that it's not either or RCTs or PROs. I think that there are many opportunities for RCTs examining PROs. We'll talk a little bit more about that later. And I very truly believe that it's not reverting to the past, it's actually moving toward the future to actually have evidence-based nephrology practice. We've had chaotic nephrology practice, which reminds me, I think I'm going to ask our faculty struggling to get their first R01 or get their papers accepted to take some darbepoetin, and maybe they'll have more academic productivity. Maybe we've not heard of the logical fallacy, post hoc ergo propter hoc. But RCT should guide our practice irrespective of the outcomes that are studied. So I do have a very distinguished opponent, as he's been introduced, a professor of medicine at Yale, absolutely internationally recognized for his work on the care of patients with CKD, and particularly as an advocate for home therapies and PD, one of the world's experts in peritoneal dialysis. And he has been leading efforts to improve the delivery of health care, including kidney care, to persons in the developing world. He's a true triple threat, a dedicated clinician, an inspiring, treasured teacher, and an influential investigator. I also think he may be He may be known as the PRO man, as he's tried to highlight. So who in the audience, and I know many of you, and I hope that you'll join me, who is familiar with the term community-based participatory research? Mark, Peter, a number of you. Who in the audience is familiar with the term community-based participatory debating? Okay, so what I would like to do is to have all of you participate in a community-based participatory debate. Now, I don't frequent the Louvre, but I do love art, and my favorite Nobel laureate will help us here. Now, I would like for you to be participatory debaters with me. Is this all right? So I'm going to start. We have a couple of verses here about randomized clinical trials in nephrology, and this will be our chorus, and I expect that at least 75% of you will sing along with me. I'll get us started. Hey, Mr. PRO man, play a song for me. I'm not sleepy, and there is no place I'm going to. Hey, Mr. PRO man, play a song for me. In the jingo-lingo morning, they won't be following you. You're going to sing with me next time. 40 years ago, our colleagues came upon a thought. Tachyuria, well, it ought to be lower than, say, 60 mg per DL. While NCDS wasn't perfect, it still taught us quite a lot. From uremia, shan't they rot. Azotemic men and women, they don't fare well. Hey, Mr. PRO man, play a song for me. I'm not sleepy, and there is no place I'm going to. Come on, Tom, please. Hey, Mr. PRO man, play a song for me. In the jingo-lingo morning, won't be following you. Now, where's John Dalgirdas? John Dalgirdas, I saw him earlier. Okay, John, sing with me. 20 years ago, our colleagues planned a major trial, randomized them for a while. DDK provided funds for us to do it. Increasing KTV was helpful, everyone already said. Low flux membranes left for dead. Hemo taught the field to question that we knew it all. Hey, Mr. PRO man, play a song for me. I'm not sleepy and there is no place I'm going to. Hey, Mr. PRO man, play a song for me. In the jingo-lingo morning, they won't be following you. Come on, you guys are weak. You gotta sing along. One more verse. Frequent hemo was the next one, just 10 years ago. Completed ample PRO, but what resulted to the patients when they followed? After 3 to 4 to 5 years, were more apt to be alive. Benefits they did derive. Note that results from RCTs, they should be hallowed. Hey, Mr. PRO man, play a song for me. Get it, song? I'm not sleepy and there is no place I'm going to. Hey, Mr. PRO man, play a song for me. In the jingo-lingo morning, won't be following you. That's an ode to Professor Finkelstein. Thank you for your good nature. Not too many thanks for the song. About 3 of you were singing. So this is an old slide, but a very telling slide, which has changed little in the last decade, but a paper from Strapoli from Jason in 2004 showing the number, quality, and coverage of randomized controlled trials in nephrology. And one can see, do I have a pointer here? Maybe, maybe not. But you can see at the bottom, very bottom, green squares of this curve is nephrology. At the very top, as you might expect, is cardiovascular medicine. But we have been at the very bottom of the heap of medical and surgical subspecialties in terms of randomized clinical trials. It's not that patient-reported outcomes aren't important, but they're confounded deeply. So maybe the history professor at Yale had a viral illness for a couple of months and was unwell, and his hemoglobin dropped, and he received some darbepoetin as his viral illness relented, and he felt better. And now he's going to be a convert to darbepoetin and receive darbepoetin. That's post hoc ergo propter hoc. That is after this, therefore because of this. So PROs are great, but we need to study them in a much less biased way than they're used in conventional observational research. So I'd like to speak with you a little bit about clinical trials, and I'd like for us to think about changing the narrative that we use for clinical trials. Randomized clinical trials are neither positive nor negative. Now, how many times, John, have you heard the hemo trial was negative? The hemo trial, what was negative about an exquisitely conducted clinical trial that informed practice? Nothing. That was a spectacular trial. Many of you in the audience were involved in that trial, and it informed practice a great deal. Randomized clinical trials either succeed or they fail. And what does that mean? Well, the interventions are positive or negative or null. But failure is an inability to reach a definitive conclusion. Success is when the trial is definitive and informs clinical practice. So let's move away from this idea of negative trials. I think we've had some negative interventions in randomized clinical trials in nephrology, but the well-conducted clinical trials have been hugely informative. And since this is RRI and it's a dialysis conference, we're going to review a couple of them and kind of re-look at those clinical trials with this idea, this different narrative in context. So let's take a walk through 40 years of hemodialysis research. We'll do it very quickly since I only have 10 or 15 minutes remaining, and there might be another song at the end. Just kidding, no more singing. So the NCDS was a remarkable trial at the time it was conducted in the late 1970s. This is the main report from 1981 in the New England Journal, Ed Lowry being the lead author. The effect of hemodialysis on patient morbidity. And as you recall, this was a 2x2 factorial design comparing patients with a high versus lower, I won't say low, but a higher versus lower time average concentration of urea as a marker of small solute clearance, and a longer versus a shorter dialysis time as a proxy for middle molecule clearance. And what this slide shows is that the groups actually were separated pretty well. So groups 1 and 3 were the lower BUN. They didn't quite make it to the midweek level of 60 mg per DL as the song suggested, but the time average BUNs were in the 50s as opposed to in the high 80s in the high urea group. And the dialysis times were about 3¼ hours and about 4½ hours. And we'll compare this trial and how successful they were at group separation to another more modern trial in just a couple of minutes. But good group separation, and these were the primary results where the very best results were observed for the patients who experienced low time average concentration of BUN, and who had longer times, and the worst, those who had shorter times and the higher concentrations of BUN. With the urea nitrogen, the time average urea nitrogen intervention with a highly significant p-value, and the time intervention with what has been described as the most significant non-significant p-value of a 0.06, which laid the groundwork for some perhaps unfavorable changes in hemodialysis practice during the 80s and early 90s. Nevertheless, this was a remarkable study conducted. This was conducted more than 40 years ago, and hugely informed clinical practice. It wasn't an enormous clinical trial, but it was beautifully conducted. I showed you very, very excellent separation between groups and definitive results. The next trial, which I mentioned, the hemo study, the effect of dose, also a 2x2 factorial design trial. Many of you were involved, George and Mark and John and Peter and others. These were the primary results, showing no difference between the equilibrated KT over V of 1.45 and the equilibrated KT over V of 1.05, and very limited differences between the high flux and low flux membranes. And by this time in practice, as you know, the low flux membranes were more or less left for dead, as I sung earlier. Dr. Finkelstein, who was a very valuable member of our research team for the FHN trial, highlighted this study of long-term effects of frequent in-center hemodialysis. And I would, just to counter my distinguished opponent, I wouldn't blame the lack of movement in terms of home hemodialysis on the lack of compelling results from the FHN. The FHN had many, many compelling results, most of which, by the way, were patient-reported outcomes. And this was, since this was a small study, this was a longer-term follow-up following patients who had been assigned frequent hemodialysis for a year. And as you saw, there was a significant improvement in long-term survival among the patients that was maintained even though they returned to their conventional hemodialysis schedules after the 12-month trial was over. I would suggest that reimbursement strategies and limitations of technology are much more important reasons for the lack of uptake in home hemodialysis than the lack of compelling nature of these results. And then most recently, the TIME trial, a fully embedded cluster randomized pragmatic trial of hemodialysis session length. And this was a feat of immense importance and immense effort on the part of Laura Dember and her colleagues. And I had the privilege of chairing the Data Safety Monitoring Board and eventually advising the NIH and the investigators to stop the trial for futility. And why? Well, and think back to the NCDS in the late 1970s, attack urea of 90 versus 50, roughly a 4.5-hour time versus a 3.25-hour time. These were the interventions. And here we were in 2017, 18, where the patients who were randomized to the usual care and to an intervention of longer session lengths, basically, this was the delivered session length. And as the trial was ongoing, that session length was supposed to be at least a half an hour longer, shrunk to about 12 minutes. So even if there were a benefit to longer hemodialysis session length, it was unlikely that the study group would find it. Whoops. And this is the, if you thought the hemo curves were superimposed, this is the superimposed survival analysis of the TIME trial results comparing the intervention and usual care. So let's just take a step back and think about the new narrative, the new way of thinking about clinical trials. We'll do a scorecard. I'd argue that for the NCDS, the intervention was positive, the results were informative, and I'd call that a successful clinical trial. For the hemo trial, the intervention was negative, the results were conclusive and highly informative, and the trial was a resounding success as a result. For the FHN daily trial, the intervention was positive, the results were informative on multiple domains, including PROs, and the trial was a success. I should point out that the nocturnal half of the FHN, which was a home-based intervention, was too small to determine there was a null effect of the intervention, and the trial failed because it was uninformative. And I would argue that for time, the intervention was negative, the effort was unbelievable, and should be congratulated, but the intervention was negative, the results were inconclusive, because if you couldn't separate the groups, the hypothesis that longer dialysis might help couldn't actually be tested. So the results for the hypothesis are inconclusive, and I would consider that trial ultimately a failure. So to conclude, I would suggest that a renewed focus on how patients feel and function will no doubt improve kidney disease and dialysis care. And I would just warn all of you, whether you care for history professors or faculty members trying to get NIH grants, that beware of reliance on observational data to inform practice. That's living in the past. Large RCTs can examine effects of treatment strategies on death and major health events, but they need not be huge, and they need not study death and major health events. The FHN was a 245 patient trial, and some of the beautiful work that Dr. McIntyre presented earlier today, that type of work could be done in 30, 40 patients. Now, his work, much of at least what I saw this morning, was open label, phenomenal, exciting material. There's no reason that those intermediate outcomes or patient-reported outcomes could not be done in a randomized manner to abrogate the problem of confounding. And so with that, I will end. No more singing, and thank you very much for your attention.